right, so thanks very much. So as Dennis mentioned, I spend a lot of time in New York City, in fact, in this neighborhood at Columbia Presbyterian. So coming back always brings back fond memories, and thank you all very much for having me. So as I get started, I just wanted to say that one of the great pleasures of being in the academic environment is that I have an opportunity to talk to and interact with so many people from different perspectives and fields, and that really makes this process a lot of fun and productive. So this first slide motivates, I think, what we're going to talk about today, but this isn't going to be news to anybody here. In terms of a global response to HIV, I think in the last decade, there has been a tremendous investment of resources shown on the left here. This is just international investments, whereas national investments today outpace international investments. And at the same time, there's a toolbox of highly efficacious clinical interventions for both the treatment and prevention of HIV. A recent study in CID suggested that perhaps 94% of expected life expectancy could be recovered with timely use of antiretroviral therapy. And then in terms of prevention, there's been really very dramatic interventions coming to the fore in the last few years. At the same time, estimates of the cascade of care in resource-limited settings suggest that these tools have not been used optimally to improve the health of populations in the real world. A large fraction of patients are not tested, those who are tested are not engaged, and many who are engaged are not retained over a long period of time. So David Aaron, who is a researcher in the VA system, I think he's based at the University of Michigan, has suggested that research to close this gap needs to be what he calls pragmatic. And he uses this heuristic of the 4 Ps to make this point. So if starting on the left here, research that is highly internally valid but not generalizable, he calls that pedantic. And research that is highly generalizable but has low internal validity, he calls that populist. And what we want to do is move to the top right, which is research that's both internally valid and generalizable. He calls that pragmatic. And I think that there are sort of, there's consensus that sort of moving to the right of the x-axis is about incorporating context into research more deeply, whereas I think moving up the y-axis is sort of about infusing research with the counterfactual perspective, at least in terms of like quantitative epidemiologic research. There is one area, though, that I think has received slightly less attention, but which is very important and is something that the field could do a lot to improve, which is the design of implementation interventions and the specification of implementation interventions. And I think, and I'll try and make a case for today, how this also is an important element of moving research towards the pragmatic quadrant. And I'll try and provide a couple of examples of studies which I think may try to highlight this concern. So first of all, why are implementation interventions hard to specify? Well, I'm going to, and I do come at all this from, I think, the perspective of a clinical researcher in the sense that my training has been clinical. And so a lot of times moving into the implementation science world comes with a certain trajectory that may be different for people who have been doing behavioral research all along. But so implementation actions are complex: training, coaching, counseling, management, contracting, sort of culture. These are actions that are complex behaviors, and so specification is oftentimes a challenge. Implementation interventions often need to conform to context and therefore include some element of adaptivity. So from that perspective, they can be difficult to specify as well. There's a concern that standardizing or defining a lot of times these complex interventions compromises their sort of like relevance in diverse settings. And finally, I do think that as compared to clinical interventions, there's oftentimes not a common physiology of mechanisms, and therefore that is something that is a barrier to full specification. To address this issue, I think Enola Proctor has done work that I think has pushed this forward. So in a paper in 2013, she suggests that implementation interventions should all have a common sort of skeleton, and this starts with an actor. So if you want to change the behavior of a system, an organization, of a patient or a provider, there needs to be an actor, and that actor, whether the training, the identity, the education, the remuneration, these things about the actor need to be specified. The actor carries out an action, and that action is characterized by a dose, a frequency, a temporality. If I'm going to do counseling, it's very different to offer counseling every day versus on a weekly basis versus on a monthly basis, right? So these elements need to be specified as a part of the interventions. The action target, she argues, is also an important piece of specifying the intervention. So the action target grossly refers to something, the unit of the target. So is it an organization, is it an individual? But more than that, I think it also refers to the capability, the motivations, and the opportunities of that unit to undertake the subsequent behavior. And in the terms of fitting this to the cascade, the behavioral target then is a necessary but not sufficient cause of, often not sufficient, sometimes it is, of a cascade step, right? So taking another example, if you want to increase ART use and you target providers to offer ART more liberally, that is the behavioral target. But of course, starting ART also requires other components. The patient obviously has to agree and want to do it as well. So I think this is probably, it's a simple but useful heuristic to bring to think about implementation interventions. This slide is too busy, I think, probably to be useful, but this is just an example of how this can be applied to different interventions at different levels. So first, at the top level, the actor could be the global fund in a particular question. It could be a QI coach. It could be an opinion leader, or it could be another individual. So these are just different examples of how you could apply this framework to a diverse set of implementation interventions. So we, as a part of some work we did with the WHO, we did a systematic review of implementation interventions targeting the HIV cascade in lower and middle income countries. And we wanted to assess, to quantify to what extent these interventions are specified according to these dimensions. So here's the result of the search, essentially. We used search terms specifying each of the cascade steps and HIV in lower and middle income countries, and we wanted to find studies that had a comparator group so that there was an intervention to characterize. And then we also did some grouping, some exploratory grouping of the interventions. We didn't find any two interventions that were identical, but at the same time, to aid summarization, you want to group interventions together in some way, shape, or form. So we ended up using a combination of sort of an ad hoc method and principal components analysis, which I'll come back to in a minute, to try and group interventions together. But here are the sort of broad stroke results in terms of the types of interventions studies. And here are the intervention types, and we essentially came up with, in 106 studies, about 400 intervention types, and many interventions have different components. So here's the rundown. As you can see, sort of counseling, point of care, and integration are the most common intervention types. And here are the types grouped into higher level summaries using sort of principal components analysis. And so they run the gamut from sort of service delivery architecture sort of above the facility level to counseling, skills development, community interventions, technology, process improvement, and things like that. So we ended up with a smaller number of intervention, we call these approaches. So here are the distribution of the quote-unquote Proctor score. It's kind of normally distributed. A few studies reported 0, a few studies reported all of them. The majority of studies sort of reported something in the middle. And here it is broken down by the type of intervention. And I should have mentioned this earlier, but we kind of thought about the Proctor cascade in two parts. So the first part is just specification of what the intervention is, and that is the actor, the action, the dose, etc. The second part of it actually gets into what the hypothesized mechanism of the action is, and that's the action target, the behavioral target, and the cascade outcome. So what I have in red is the latter part. It's the sort of mechanistic part. Just maybe I'll stop for a second to give an example of where that boundary is and why I think that's an important boundary to highlight. So a few years ago, I did some TA in China for clinical HIV care, and I don't know if any of you have worked in China, but it's common to use mannitol to manage intracranial hypertension. And outside of China, that practice is essentially sort of never done. I mean, in the United States, we manage intracranial hypertension with serial lumbar punctures or drains if need be, et cetera. And so my job was to kind of like round with a team of doctors and junior physicians and residents and talk about cases. And so, at one of the cases was a patient with cryptococcal meningitis who was receiving mannitol. And I talked a little bit about lumbar punctures and the evidence and why mannitol in theory might not work and there's no clinical evidence, et cetera. And she said to me, she said, "Thank you, that's nice. It's nice to know that's how you do it in America, but in China, this is how we do it." So in this particular instance, I was the actor of the intervention. Sort of rounding, coaching, and training was the action, but the residents were the action target. But more than that, the action sort of never reached the action target because even though we were having a conversation, it was not acceptable to her what I was saying. So if you were to examine this intervention in a systematic way, you would find that there was no effect. And you would have to, you could go back and say, this is where it broke down. It's not that the action didn't happen, it's that the action never reached the action target. So that's the sort of boundary between these things. But I just want to point out a couple of quick things about this, which is that there's overall reporting is not high. There are areas where it seems to be a little worse than others, and further down the sort of cascade is slightly better than before. And we didn't fully characterize this statistically, but these are just like the trends visually. Here is the same when broken down by steps in the cascade. And so here we see, for example, there are quote-unquote hotspots. So the dose and temporality of interventions to promote testing is often not specified. Many of these are not fully specified retention on ART interventions, whereas sort of the action and behavioral targets are in general somewhat better specified. So coming back to the consequences of inadequate intervention specification. So some of them are quite obvious, right? So if you don't specify the intervention, it's very hard for someone else to reproduce it. And if you don't reproduce something similar in different settings, it's very hard to say that something is generalizable. So that's one. Second, it also undermines what we do scientifically in terms of synthesis, either formally through meta-analysis or informally through my individual read of the data. And in fact, people who are doing, for example, network meta-analyses now do group a lot of these studies together. And you'd have to sort of wonder if what the consequences are of grouping studies together that are actually quite different in reality, and what that actually tells us. And then finally, the specification of the intervention and the mechanism, as well as the attendant measurement of those steps, helps us understand why something worked when it works and why something didn't work when it doesn't work. So I use this example, this analogy of a house. So if the house collapses, you want to know whether or not the blueprint for it was bad or the construction was faulty. But unless you specify the blueprint very well, you can't sort of know that and go back in retrospect. There is another sort of piece of this that I think is less well appreciated, and certainly something new for me, is that when we don't specify hypothesized mechanisms, it undermines our ability to infer about results in one setting in another setting. So that's generalizability. And there isn't sort of a self-evident way to show that. But there's an emerging literature in causal inference about transportability that makes that claim. But I also wanted to use a very nice example from clinical medicine that I think makes this obvious. So so protease inhibitors have in vitro a direct effect against Plasmodium falciparum. So there's an idea that they obviously treat HIV, but they might actually have anti-malarial effects, even though it's never been studied clinically. But protease inhibitors will also alter the pharmacokinetics of anti-malarial drugs. So in a randomized trial in Uganda, children who had HIV were randomized to receive either PIs or NNRTI-based regimens. And what they found was that the children who received the PIs had as a group had a lower rate of malaria. In fact, the rate of malaria was cut in half. And it was statistically significant, and that was the top line result of the study. So what they also did, though, was that they put down blood every 12 weeks, and they went back and looked at two things. One is when the episodes of malaria were, and secondly were the blood levels of the respective drugs. So on the right, you can see that overall there was no difference in the first episode of malaria, but there was a very big difference in recurrent malaria, and that recurrent malaria rate was directly proportional with the levels to which the ritonavir boosted the anti-malarials. Sorry, this is I realize that I might be skipping a step here. So the protease inhibitors change the pharmacokinetics and often increase the levels of other drugs, right? So that's the gist. So the mechanism informs generalizability, because if this occurred through a direct antiplasmodium effect, then the effect is transportable to other places. If it's only through boosting the coartem, then it's only transportable to places with high malaria prevalence, right? You wouldn't, if the average kid is not going to get malaria more than once in a low prevalence area, then this intervention is unlikely to have any clinical effect on malaria. So the mechanism informs what we think about generalizability. Okay. So I've actually lost track of time, so somebody can yell at me if there's a second half. So I think that so we want research to be pragmatic, right? Because we want it to be generalizable, which means that we can think about what it means somewhere else based on results sort of in one place. But we also want it to have impact. So there's a z-axis here. So we want interventions that are both generalizable and have generalizable impact. And so what I want to spend a little bit of time talking about are just sort of strategies that I've been involved in and others sort of emerging about how we might think about interventions that have generalizable impact. Certainly this is very much work in progress, so I'm happy to hear reactions and queries about it. So to talk about this, I'm going to invoke Rothman's causal ties, the heuristic that he offers about thinking about causality. So in this particular approach, he says that a circle is a sufficient cause. So when you have a circle, something happens. A sufficient cause is made up of pieces of the pie, which are component causes. So generally, when we think about whether or not something happens, for example, whether or not ART is started by a patient, one component cause is that the patient needs to want to start it, and then another component cause is that the physician needs to prescribe it. And so when you have all those things, then you have a sufficient cause and the thing actually happens. And one way to think about generalizability is to think about it as sort of heterogeneity across settings as an underlying difference in the distribution of component causes. So you have population 1 and population 2 here, and I've just thrown up some hypothetical sort of distributions of underlying component causes. These could be sort of psychological, they could be economic, they could be other things. And then across the top are some intervention sort of typologies. So you could, depending on what there are certain groupings of interventions that could, in theory, have more effects across diverse populations if you offer something closer to a sufficient cause, right? So here, if you offer one blue thing, in one population 1, the difference is you change the probability of the outcome. The probability of the outcome is 0.4 versus 0.2, 0.6 versus 0.2, and then sort of 0.8 and 0.8. So the last one is the most kind of robust across different settings. And the trick is, though, to find, I think, that set which is parsimonious and principled. And that's why I call this the PPKS. Because you could just give everyone everything all the time, right? Like in terms of if you did a research study and you wanted to show efficacy, you could give a voucher, counseling, transport. You could do everything, but of course that's not going to be easily reproducible in the real world. And many of these things actually do have side effects that we don't fully understand, but it's not a good idea. This takes as a point of departure that it's not a good idea to give everybody everything all the time for various reasons. So here's an application of PPKS. So an attempted application. So in the cascade of care, I think we and others have shown that ART initiation was a problem in many low and middle income countries. So even among patients who come to clinic, who are in clinic, who have either clinical or CD4 eligibility for ART initiation, something like a third to a quarter either started after a long delay or never started. And so that was a step in the cascade, even though the modelers say that it's not driving the epidemic. From a clinical point of view, it's something that the health system could really do something about. Like, we can change that. It's within our ability in the health system. So, but why was this? So our preliminary work sort of led to a 3-part diagnosis. So first of all, overnight processing of CD4 count is a problem, because you come to clinic, you get an unclear message, which is that you may or may not need treatment, and then you need to come back to get the results of this test. And there are patients that are lost in that process because a lot of times people don't come back or they don't understand that message. There's organizational issues. So for whatever reason, in low and middle income countries, it became extremely prevalent to have 3 pre-ART initiation counseling sessions. So because adherence was really emphasized. And so it became this thing where you had to do all 3. So there are people who failed to do all 3 or got sort of tired of doing it after 2 and then just didn't come back for the last one. And then there was also this practice of getting a treatment supporter, you needed to bring somebody with you to say they would vouch for you and also help you. And if you don't have a treatment supporter, that became a barrier to treatment initiation. And then finally, the providers. So in 2011 and 2012, there were a few clinical trials that showed that among patients who were symptomatic, if you delayed antiretroviral therapy, even by a few weeks, that it had measurable impact on AIDS progression and in some cases mortality. But that information is presented at CROI, and it doesn't necessarily make its way to the frontline healthcare workers in rural Uganda, for example. So those were all barriers. So using a theoretical framework that Larry Green came up with, we tried to fashion a set of interventions that were parsimonious and principled, but which sought to deliver as much of a sufficient cause as possible. So one way of parsing component causes, Larry Green says, when you want to change the healthcare behaviors, in this case of healthcare workers, is that you need to have a predisposing, an enabling, and a reinforcing factor. So the predisposing factor makes people want to do what you'd like them to do. Enabling makes it easier for them to do it. And then a reinforcing factor is essentially an incentive. So if you do it, something good happens. If you don't do it, something sort of less good happens. And there is actually a paper from 1992 in JAMA where he looked at interventions among healthcare workers and tried to identify these three components, and there was a statistically significant greater effect in interventions that had all three versus interventions that had one or two. But this isn't the only framework you could bring to sort of like parse a diverse set of interventions. I mean, there are many other theories. I mean, diffusion of interventions is many theoretical frameworks for this. So in this case, our actor was an opinion leader, led sort of continuing medical education, plus introduction of a PIMA machine, which was a point-of-care CD4 count machine, and also a feedback mechanism so that each clinic would see how they were doing in comparison to other clinics. The action was, sort of training and coaching around these things. I have some information there about the dose and the target. The target was the healthcare worker, and the objective was to ask them to prescribe ART more. So I may have a little PowerPoint snafu here. I'll come back to the red in just a moment. So, okay, so I won't present the results here because they're sort of immaterial for this particular talk. But there was a large effect on ART initiation, and the ART initiation on the same day of eligibility determination went from essentially sort of like 78% to 75%, and ART initiation by 14 days went from essentially 30% to, depending on which clinic, somewhere between 75 and 85%. So the intervention had a relatively large effect, and we studied this in a stepped-wedge cluster randomized way. So what in terms of mechanisms, so because mechanisms of behavioral interventions can't be often, you can't sort of put perspective, like there's no serum level of something, right? So you can't just store blood samples and then like do it later. So we used mixed methods to try and understand mechanisms, and indeed we found something that we did not expect at all, which was that the intervention influenced healthcare workers at the facility, but that in turn influenced the cadre of peer health workers at the facility, who then influenced patients during the preparation process and even in the community before the patients ever encountered the healthcare workers for the first time, right? So we thought of this as a supply-side intervention, and we implemented it as such, but qualitative work showed that it was actually both a supply and a demand-side intervention, so that part of the effect was mediated by the cadre of peer healthcare workers. And I just want to highlight that because it does, in my mind anyway, have implications for generalizability. I mean, this intervention is going to have more of an effect in a setting where that cadre exists, and that there's a trusting relationship between that cadre and the formal healthcare worker sector, and a trusting relationship between that cadre and the community. In the absence of that, my guess is that the effect of this intervention would be attenuated, and so that's one illustration of this PPKS. So another approach is adaptivity, which is like a very large topic, and I'm going to just use the same heuristic to illustrate what I mean by adaptivity. I mean, it's obviously everything I'm going to say here is going to barely scratch the surface of this very large topic, but So again, say there's population 1, population 2, differential distribution of underlying component causes. And so the first column is PPKS, right, where we give everybody something near a sufficient cause, and that will have the same effect everywhere. Another approach is to try and deliver the missing piece to where it's sort of needed. And oops. And that would be sort of giving the one who's missing a blue piece, and giving the one that's missing half, half, et cetera. And the advantage of that over a PPKS is that it could be more sort of efficient. But the question is, though, how do you actually adapt an intervention in the sort of right way? I think that is a challenge. So in the clinical sciences, there's this tremendous amount of work where you characterize an individual like sort of genomically, and then you give them a treatment that fits them. But again, I think in the behavioral world, we don't have that level of sort of that kind of concrete underlying. There isn't an analogous sort of behavioral DNA, at least that I'm aware of. And so it becomes, the question is, how do you adapt interventions to individuals? So using another example in work that I was involved with IDEA, and Dennis knows about this work, but we looked for patients who were on care and treatment in Africa who were lost to follow-up, and we essentially asked them why they had stopped coming back. And as you can imagine, the reasons were very diverse. And I've just shown this, not to show you the individual reasons, but just to show you that there's like this tremendous distribution. So a lot of people had problems with transportation, that's on the far right, but they had, many people had problems with many other things. Many people had multiple problems. Some people had single problems, and these problems overlap. So somebody might have a transportation problem and a psychological problem. Another person might have a disagreement at the clinic, and therefore have a problem with that specific clinic, and so the reasons are diverse, and we thought there was no sort of silver bullet that's going to solve this retention problem for everyone. But short of that, one strategy that has been used to start looking at how to use existing interventions to meet the needs of populations is this idea of what's called a SMART, what people are calling a SMART, which is a sequential multiple assignment randomized trial, where you take interventions that target different things, but you don't know who is going to be targeted by which interventions, and you offer it to people, and you see who responds, and then you offer something different to people who don't respond optimally, whereas you maintain the treatment in people that are responding optimally. And so the psychiatrists have been using this technique for a long time. I think oncologists have as well. And so it's sort of a growing thing that we thought had applicability for the problem of retention in HIV care. On one level, this is actually sort of like beyond obvious, right? So when people do clinical practice, this is exactly what you do. You say, I'm going to treat somebody for alcoholism with, certain something, and then the patients that sort of respond, it's like, okay. And then the patients that don't, you try something else. And that is how clinical practice is essentially done for very many things. This just formalizes that process, right? So that you apply the same decision-making algorithm to many people, and therefore you can study it quantitatively, because otherwise my adaptive approach and Dennis's adaptive approach, it will be different, and there's no way to summarize it all. But this study's in the field in Kenya. It's just getting started, but essentially we randomize people to different interventions that have known or good evidence for efficacy, and then we re-randomize the patients who don't succeed. And in fact, for the patients who receive a voucher and who succeed, we will re-randomize discontinuation of it to see how sustained it is. But that's that's a second strategy. So, thanks everybody for listening to this. The second part is very sort of exploratory, but I mean, I think that implementation interventions face challenges to optimizing sort of generalizability, and the standardization of specification can help with that problem. The specification of mechanisms is also something that will be useful for that. And then, there are strategies that, and there are probably many out there that we haven't sort of occurred to us, but that are either adaptive or multi-component, that can strengthen the impact of the robustness of interventions across heterogeneous settings. Anyway, I think that brings me to the end, and let me stop there and look forward to your reactions and questions. Thank you.